Hi guys, welcome back. We're in week 13 at this point, musculoskeletal, but I didn't really post a review, an overview PowerPoint for last week, just because there were so many PowerPoints already posted. I didn't want to overwhelm you guys. And I really wanted to kind of do more of a focused review and summary on both weeks 12 and 13, as well as just talk about what's incorporated into this review, as well as the next exam. So here we go. We're going to start with the nervous system first. And again, this is just to really focus in on a few of the more important things that I wanted to make sure you're reviewing, and that's important for clinical practice. But this is in addition to, of course, the PowerPoints that are already posted. Those are a lot more detailed. So just definitely review those as well. So I just wanted to make sure we have a basic review and understanding of the nervous system. Make sure you can differentiate between the central nervous system and the peripheral nervous system, and the associated organs, as well as the enteric nervous system. Let's watch a quick visual review of the nervous system and function, just so we have a nice review and we get a visual view of it. There.
The function of the nervous system is to provide rapid communication and integration between various organs, as well as with the outside environment. It detects changes within the body and in its surroundings, and responds accordingly. Fast communication is achieved by means of electrical signals known as nerve impulses, which are generated and carried by specialized cells, called neurons. The major components of the nervous system are the brain, spinal cord, and nerves. The brain, enclosed and protected in the cranium, is the central processing center. It receives information, makes decisions, and coordinates the body's response. The spinal cord, enclosed in the spinal column, functions as a communication gateway between the brain and the trunk and limbs. Nerves are cord-like structures that conduct information, similar to electricity conducting wires. They are composed of axons of neurons, the cell bodies of which are clustered in knot-like structures called ganglia. Ganglia commonly serve as relay centers, where neurons synapse and transmit information to each other. The brain and spinal cord make up the central nervous system, while nerves and ganglia constitute the peripheral nervous system. Functionally, a nerve fiber can be sensory or motor. Sensory nerve fibers carry sensory information from sensory receptors to the central nervous system, while motor nerves conduct motor instructions from the central nervous system to effector organs, the muscles and glands. Nerves that contain both sensory and motor fibers are known as mixed nerves. There are two major groups of nerves, cranial nerves and spinal nerves. The 12 pairs of cranial nerves emerge from the base of the brain and relay information between the brain and the head and neck regions. The cranial nerve 10, named vagus nerve, also communicates with internal organs. The 31 pairs of spinal nerves arise from segments of the spinal cord and innervate the trunk and limbs. Spinal nerves communicate with the brain via the spinal cord. All spinal nerves are mixed nerves. They contain both sensory and motor fibers. Typically, sensory receptors send impulses by way of sensory fibers in spinal nerves to the spinal cord, which relays the information up to the brain. The brain interprets the information and sends back instructions down the spinal cord to motor fibers in spinal nerves to reach effector organs. The peripheral nervous system can be divided into somatic and visceral subdivisions. The somatic nervous system includes sensory nerves from the skin, muscles, bones, and joints, and motor nerves that innervate skeletal muscles. This system controls voluntary muscular contractions, as well as involuntary somatic reflexes. The visceral nervous system, on the other hand, includes sensory division that detects changes in the viscera, the organs in the thoracic and abdominal cavities, and motor division that controls cardiac muscle, smooth muscle of internal organs and glands. It produces, for example, faster heart rate and breathing rate during physical exercise, and slower cardiorespiratory rate during sleep. The visceral motor division is also known as the autonomic nervous system because it is largely autonomous, acting independently of the body's consciousness and voluntary control.
All right, hopefully that review was helpful. I always love a visual guide. Okay, important things to just make sure you review in terms of your readings is looking at strokes and are they ischemic versus hemorrhagic? All right, we want to make sure you're reviewing the pathophysiology of each, the clinical manifestations, and the labs that you would be looking at in terms of trying to diagnose either or. Okay, brain structure and function. Just make sure that you are aware of the structure and each function involved with the structure, including amygdala, the basal ganglia, your prefrontal cortex, and your sensory cortex, okay? Make sure you review those. Another big thing I wanted to make sure that you are reviewing and really have in the back of your head, because it goes, basically these neurotransmitters apply to everything in pathophysiology as well as pharmacology. So you want to make sure you know your neurotransmitters and the associated function, okay? Especially your acetylcholine, your dopamine, your norepinephrine, and your serotonin. All of them are important, but those in particular, obviously. Next, we want to make sure that we have reviewed our motor disorders and the pathophysiology accompanied with it. Keep in mind on table 15.3 in the book, they do a nice review. I just threw this video in here as well, because I'm always like partial to being able to see what the actual disorder looks like. And I thought it would be helpful for you guys. It's quick also.
In this video, we'll talk about motor disorders. And what I mean by disorders is disorders affecting somehow your skeletal muscles, your voluntary muscles. We'll be comparing upper motor neuron lesions to lower motor neuron lesions and what each of these mean. In order to understand upper and lower motor neuron lesions, we must recap the motor pathways, looking at the pyramidal system, which is a system of voluntary movement. Normal motor function depends on the transmission of signals from the brain to brainstem or spinal cord by the upper motor neurons, and then from there to skeletal muscles by lower motor neurons. Here is a cross-section of the primary motor cortex of the brain. The outer gray matter of the cortex have areas where neurons arise from, which are associated to a particular area in the body, so the feet, hands, and the face. The white matter consists mainly of neurons' axons, which travel through the brain. Motor neurons will pass through the internal capsule situated near the thalamus and basal ganglia. Here is the brainstem, which is made up of three parts: the midbrain. Important area here is the red nucleus and crus cerebri, and the pons, not drawn, as well as the medulla oblongata here. Here is a cross-section of the spinal cord where the communication between upper and lower motor neurons occur. We will learn about this soon. The spinal cord have tracts, which are where neurons travel through. Important tracts in the pyramidal system are the lateral corticospinal tract and the anterior corticospinal tracts. The target organ of the motor neurons are the skeletal muscle cells. Let's create a scenario where we want to move our right thumb. The upper motor neurons arise from the left primary motor cortex, pass through the internal capsule, through the brainstem, passing the crus cerebri, passing through the pons, and then passing through the medulla, the area called the pyramids. Hence, it's called the pyramidal system. The vast majority of upper motor neurons that project from the motor cortex to the spinal cord are contained in the lateral corticospinal tract. The neurons that will travel through the lateral corticospinal tracts will cross over at the medulla of the brainstem. Once the upper motor neurons reaches the correct spinal level, it will synapse with the lower motor neurons at the anterior horn of the spinal cord. The lower motor neurons will then target the skeletal muscles responsible for movement of that body part involved. So in this scenario, it is the muscles involved in the right thumb movement. Majority of upper motor neurons are contained, as mentioned, in the lateral corticospinal tract. However, there are those that project to the proximal muscles, and these have axons that do not cross over at the medulla, but actually travel in the anterior corticospinal tract in the spinal cord. Axons of the anterior corticospinal tract will cross over when they reach the level of the spinal cord, where they will form synapses with the lower motor neurons. Hope that all made sense. Now it's important to realize two things here. The first is the general rule in which motor neurons activated on one side of the brain will control movement of the opposite side of the body. Second thing to remember is that the spinal motor tracts we discussed are under voluntary control. There is another motor tract which is also under voluntary control called the rubrospinal tract. Now, the rubrospinal tract originates in the red nucleus of the midbrain. It decussates and then descends in the lateral aspect of the spinal cord, where it will synapse with a lower motor neuron. The rubrospinal tract targets lower motor neurons, which facilitates in muscle flexion and inhibits neurons in muscle extension. Now, in summary, the upper motor neuron transmits information from the brain to the spinal cord or the brainstem. Lower motor neurons transmit information from the brainstem or spinal cord to the skeletal muscles. Clinical findings on examination can indicate whether a motor disorder is due to an upper or a lower motor neuron lesion. However, before going into the clinical examination, let's look at some causes of upper and lower motor neuron lesions, beginning with the upper motor neurons. Remember, the upper motor neuron transmits information from the brain to the spinal cord or the brainstem. So really, any injury to the brain, such as stroke, infection, or tumors, can cause upper motor neuron lesions. Similarly, any injury to the brainstem or spinal cord, specifically the white matter of the spinal cord on the outside here, where the upper motor neurons are traveling through, can cause upper motor neuron lesions. Lower motor neurons are the neurons which transmit signals from the spinal cord or brainstem to the skeletal muscle. Lower motor neuron lesions are caused by any damage along this tract. So, for example, injury to the axons leaving the spinal cord can cause lower motor neuron lesions. Injury to the spinal cord itself as well, particularly to the ventral gray matter of the spinal cord, the anterior horn of the spinal cord, because this is where the lower motor neurons start. It's quite amazing because through doing a proper neurological examination, you can sort of figure out whether a motor disorder is due to an upper or lower motor neuron lesion. Let's look at some of these signs on examination, beginning with upper motor neuron lesion signs. Again, the signs elicited on examination, of course, depends on what area of the motor pathway is affected, which side of the brain, the specific spinal cord level affected. But we won't go into that detail, just remember these overall signs. With upper motor neuron lesions, you would have minimal muscle atrophy. You would have weakness, as the other neurons from other areas can sort of help with muscle movement still. When you test the deep tendon reflexes, such as the patellar reflex here, you would be hyperreflexic. The reason is a bit complicated, but essentially with a deep tendon reflex where the spinal level is unaffected, the reflex is amplified because there are no upper motor neurons which are regulating the reflex at that level. However, in upper motor neuron lesions, there is diminished or absent superficial reflex. the Babinski sign is positive, where if you scrape the sole of the foot, what will happen is dorsiflexion and fanning of the toes. With lower motor neurons, there is muscle atrophy because the actual neurons which supply the muscles are not getting there. Flaccid paralysis is present. Normal or no plantar response because no signal are arriving at the muscles. Similarly, there is absent tendon reflexes. You can also see fasciculations of the affected muscle. This is where single muscle fibers are still stimulated. The reason for this is because there's still some transmission, some signals from lower motor neurons, which are not fully injured. So that was the overview for upper and lower motor neuron lesions. Motor disorders or deficits can also arise from other problems. For example, disorders or problems of the skeletal muscle specifically. An example of this includes necrotizing myopathies or electrolyte changes such as hyperkalemia or hypokalemia. Motor disorders can also arise from neuromuscular junction disorders. The neuromuscular junction is where the lower motor neurons will release chemicals which will stimulate the muscle fibers. Example of neuromuscular junction disorders include myasthenia gravis, botulism, and aminoglycoside toxicity. If you want to learn more about the pyramidal system or other neurology topics, check out the playlist or visit armandoh.org.
All right, great, guys. I love that video in terms of his explanation to the clinical manifestations of upper and lower. I will list the videos that I've been posting in a separate page, so that way you guys can directly have access to them. It didn't occur to me that you couldn't click on them through the video, but I realized after you can't. So I will make sure to have a list separate so you can click on it. So that's it pretty much for the nervous system. Now getting into musculoskeletal, just make sure that you review your landmark muscles and skeletal system, of course. You want to be able to differentiate like biceps, sternocleidomastoid versus mandible, clavicle, humerus, just the basics. Just make sure you're able to recognize and differentiate as well as document and spelling them appropriately. Definitely want to make sure you're reviewing the various fractures and the characteristics of each. These will definitely be on the boards at some level. Remember, when would you be at high risk for infection? Take a guess looking at this. Anything that would be open would be at high risk for infection. So just keep that in mind in terms of your fractures. Next, I wanted to get into herniated disc disease. Just make sure that you know what it is, how it manifests itself on the spinal cord. You want to know location of dysfunction and the associated motor deficits. So just be very clear if like if a lot of the times they'll give you a clinical question manifesting where the pain is coming from, and then you have to localize which is the associated nerve root. So you want to just be aware of where on the spinal cord and what clinical manifestations occur with each associated nerve root. Okay, definitely want to be aware of osteoporosis, what it looks like, how it manifests, the risks, the symptoms, how to prevent it, and what to educate your patients on. You definitely want to know risk factors in terms of who's at high risk and treatment. So in summary, guys, just in terms of preparing for exam 3, make sure you're reviewing all of the following chapters. These will all be on the exam. This was from every module since the last exam. So that was 11, 12, 13, 15, 16, and 17. In each chapter, just make sure you're using your book to your advantage. Sometimes the book goes over the top in terms of, the amount of knowledge we need to know in different things. and what you can actually retain. So the things that I would focus on in terms of reading your book and outlining your chapters is, first of all, focus on your key points. Remember, those are found at the end of each chapter. Those are going to be what basically is a summary to your chapter. And then you want to go through each key point, see what you need to understand a little more, and then go back through your readings and kind of review definitely any diagrams or tables that are listed, because that can be very helpful in terms of just really getting an overview of what the key things are within your chapters. You want to also review the clinical context, which is at the beginning of each chapter. That's an area that, basically kind of summarizes and gives you a pre kind of situation to give you an idea of how to apply that particular system, like in this case, chapter 15, the nervous system, towards your clinical practice, and how like it may manifest, the pathophysiology of a disease process or system may manifest within your clinical practice. So that's super helpful in just kind of giving you an idea of what is to come and why it's important for you. And then, of course, reviewing the thought questions throughout the chapter just to solidify the context of your reading. Just make sure you use those to your advantage. Like if you have no idea what they're talking about, then you need to go back and reread those few paragraphs. Definitely review the bridge to clinical practice. That's also kind of at the end of each chapter. This box is a definite help with understanding, again, how the pathophysiology of that disease within that chapter applies to clinical practice. In this box, they're reviewing the labs, the diagnostic tools, the major drug classes used for that particular disorder of the system, as well as the non-pharmacologic modalities they can sometimes incorporate. And they're presenting it, as a review, like as if, that's how it's pretty consistently presents in practice. So, this is basically a very common thing, and this is how it presents, and this is the pathology that you would take in terms of diagnosing, and treating. So definitely use that to your advantage as well. And then, of course, the study guide will be posted shortly. Use this study guide to your advantage, create an outline around the study guide, and that will definitely 100% help you be successful on this exam. I hope this was helpful, guys, and I wish you the best of luck. And thank you so much for your time and effort in being successful in this class. I know it is very, very overwhelming at times because it's a lot of information. The one big thing I need you to remember when you're studying in pathophysiology is, to learn, especially in grad school, and remember once you graduate, how much you don't know. And you're just at the ice, cutting at the very, very, very edge of the amount of knowledge that you actually have to learn in order to understand the depths of each of these systems. But the important thing is you're just able to realize, the key points, that what reference tools to use if you needed to find out more information, if you're in the process of diagnosing, and just understand the depths of each system and how it applies to your treatment plan and how it's going to affect your patient's life. And that's the important thing that you really need to try to get out of this particular class. Every one of you wrote an awesome paper. I would encourage you just to look at your formatting prior to submitting papers at this point. And you're in grad school. The information you guys presented is excellent and could be used in all kinds of educational tools. And I'm really, I would definitely encourage you guys to keep those and use them as reference tools for when you study, both the ones you created for yourselves as well as your colleagues. All right, thanks. Have a great week and good luck with your studies.